Hi, and welcome back to The Real Tea on PNP. My name is Akira Bias, and I'm your host, and I'm here with the lovely Dr. Joselyn Rodriguez. So before I begin and talk about her bio, I just want to say that I'm really excited that she's here. You're our very first guest, so welcome. I hope we have a very riveting conversation. I hope we get the opportunity to just learn more about what you do and how you service your patients, and to help people who may not know necessarily that they need a pelvic floor therapist. So with that, thank you so much.
Thank you for having me. It's a pleasure.
Of course, of course. So Dr. Joselyn Rodriguez is a board-certified orthopedic specialist in physical therapy with additional training in dry needling and pregnancy and postpartum exercise. As a graduate of the University of Michigan and the University of St. Augustine for Health Sciences, Dr. Rodriguez takes a full body approach to pelvic floor care. Originally from Brooklyn, New York, she is passionate about addressing pelvic floor health disparities and educating both patients and peers. Dr. Rodriguez has been a panelist on women's health and a speaker for the Florida International University Black Mothers Care Program. She's also a published author of a retrospective study on constipation, and Dr. Rodriguez treats both men and women and she's also a native Spanish speaker, which is very helpful given that we are in Miami. She is committed to increasing pelvic floor awareness and providing compassionate care. Dr. Rodriguez is also the owner of Jae Physical Therapy, which I'm sure she will share a little bit about. And outside of her professional life, she married her college sweetheart, and they've been married for 16 years, and they have a 6-year-old daughter. So once again, welcome, Dr. Rodriguez.
Thank you so much for having me.
Thank you, thank you.
I'm really honored to be here. I'm honored to be your very first guest.
Yes, absolutely.
Thank you for thinking of me.
Of course, of course. So I just wanted to know, can you just tell us a little bit about yourself and also give us a background on what is a pelvic floor therapist?
Sure. So as you shared, I'm from Brooklyn. I'm from New York City, went to school in Michigan, studied athletic training. So I was heavy into movement, the medical side of the athletic world. And it wasn't until after that I became a physical therapist and was pregnant that I realized, wow, nobody taught me anything about what to expect with labor and delivery. And I definitely didn't prepare for it. Mm-hmm. And I thought that maybe that contributed to my own injury and my own birth trauma. And after working with other pelvic floor therapists, I said, you know what? I think this is something I can do. And I think I can do it for my community. And I think that I can better prepare people than we are currently. And so that's kind of what my focus is.
Wow, that's great.
People.
Yeah, and a really cool fun fact, I remember reading in your bio, you said that you took your boards 37 weeks pregnant. So how was that? I can't even imagine that.
There was extra breaks for bathrooms. I ended up using less time to actually take the test because I really needed to go to the bathroom. But, I always tell people that I cheated because I had 2 brains. But it was definitely an experience. I'm glad we got the math right. Because it was a planned pregnancy, and I'm glad we got the math right.
Okay, yeah, absolutely. So, as a pelvic floor therapist, what are some common pelvic floor issues that you see in pregnant and postpartum women?
So usually lots of pain, unfortunately, because of the changes that happen in women's bodies as the baby gets larger and larger, they take up more space. They will have, inevitably, usually, pelvic pain. So it's usually either in the front, the middle, called pubic symphysis pain, or it could be in the back, SI joint pain.
Okay. So when you say SI joint pain, so what does that happen? Is this something that women are common to? Is this something that happens sporadically? How can they prepare themselves for that?
They can absolutely prepare themselves for that. And that's why I do what I do, right? I see women prenatally to help them with their aches and pains so that they can just have a happier pregnancy, right? So many people think that pregnancy is, a burden and you have to just take it, but that's not what you have to do. You can actually do things to make your body feel better. And studies do show that women who exercise during pregnancy have better pregnancies and have better postpartum outcomes as well, right? So with SI joint and pubic symphysis dysfunction, the best things you can do is strengthen the hips, strengthen the body. The body during pregnancy, with all the hormones, it's expected for the joints to become more lax and looser. That's to prepare for labor and delivery. So that's expected. But with that comes instability, and the strength that your muscles can provide more stability.
So for someone who may not necessarily be versed on pelvic floor issues, how do you explain that to new clients or just people who are unfamiliar with the topic?
Sure. So pelvic floor dysfunction can be can present as bowel, bladder, or sexual dysfunction. In addition to like pelvic pain, abdominal pain, hip pain, back pain. And because the pelvic floor helps with all those things, but then it also supports the body. Anytime you move a limb, your pelvic floor naturally contracts beforehand to provide stability to the body, right? So we're all using it. We just don't know that we're using it.
Yeah, absolutely. Like I didn't even think about that, but you're right. Like whenever we're walking or doing any types of movements, we are using our pelvic floor. So what are some common myths, right? So like you're telling us like how our pelvic floor helps us, but what are some common myths about pelvic health that you wish more people would kind of like know the truth about?
Yes. The first one is that only women have pelvic floor issues. That's the first myth. And the other myth is that it's only women who've born children, right? And that's not true. Right? Any woman can have, there are girls who just get their periods and all of a sudden have significant pain, right? They realize that, oh, I can't get a tampon in. That's pelvic floor dysfunction, and they'll go into adulthood and say, oh, I can't use tampons. Or they have their first medical exam with the gynecologist and they realize, well, they have their first and it was extremely painful and they think they're all supposed to be that way, right? That's, I think, one of the worst things is that we normalize the bearing it part. Like, oh, I just have to get this done because I need to have my pap smear. Okay, yes, you do need to have your pap smear, but we can do this in ways that will provide less pain and have more positive, results and influences, right? And for a lot of people, those people who have trouble with tampons and they have trouble with medical exams, they also go on to have pain with intercourse when they decide to have penetrative intercourse. And again, it's it's painful, it's expected to be painful. No, intercourse is supposed to be pleasurable for all people, right? And so because I think we focus so much on the penetration and there's lots of stress on that, there's lots of societal expectations on that, a lot of women just go through it, right? And they're like, well, this is my duty, this is what I have to do, but okay, but like, why?
Yeah. Do you feel like women in spaces are just uncomfortable having these conversations? Because I don't think I'm comfortable having conversations even with my bestest and closest of friends.
This is so true. Yeah. It's difficult. It's a taboo topic, whether you're talking about intercourse, whether you're talking about bowel or bladder issues, like urinary incontinence or even fecal incontinence. A lot of people aren't talking about it. If you think back to our own mothers, there were signs of pelvic floor dysfunction. Maybe, she always had to change her underwear frequently or change her clothes often throughout the day and you didn't understand why, or maybe she never participated in, playing, running, jumping on the trampoline with you, right? There are signs everywhere that we just don't talk about it enough. Oftentimes when women go on to have their own kids is when they develop that better relationship with their mother, because now they feel more connected and they feel like there's that veil lifted where they can speak more, freely about what mom has been going through all this time, but now you are going through it because you're now a mom, right? When you talk about, pain with intercourse, who's talking about that with their friends? They're probably not even talking about it with the partner who's contributing to their pain.
Absolutely,
which is super sad, right? When you think about that you're going into this vulnerable position with someone who's supposed to really look for your own best interest and you can't share that with them, So I think for men too, there's the taboo. How many men have erectile dysfunction, and they're quick to go get medication, but they're not quick to go find a holistic approach to improve that, right? That could be as simple as, more cardiovascular exercise to improve arterial blood flow, right? And capillary blood flow to the penis.
Yeah.
So there are so many facets of this because of where it is, right? It's a very, intimate area. And a lot of people just don't talk about it, right? But that's why I do what I do.
Absolutely. So do you think that patients should they be required to do the first step in terms of bringing it with their doctors? Or do they feel like the professionals are not doing a good enough job asking the right questions or making them feel comfortable? Like how does a patient feel comfortable?
Yeah. So I think that if you think about traditional medicine with physicians, they're limited in their time with their patients, right? And if they're coming in for a problem visit, they're very specific with that one problem, right? You maybe have gone to see an orthopedic physician and they're like, oh, you're here to see your ankle? I'm only seeing your ankle. You want me to see your knee? You have to make a separate appointment for that, right? So I think the dynamics in that 15-minute visit with a physician does not allow for you to go in deeper, right? When you see a physical therapist, hopefully it's one-on-one, and you have 45 minutes to an hour to talk about what's going on. The reason why I went into physical therapy and I was considering becoming like a PA or something like that, a physician assistant, was because a physician assistant is still in that medical model where it's a quick visit. Whereas as a physical therapist, I really get to know my patients. I'm seeing them 1 to 2 times a week for at least 6 weeks. You know, I really get to know them. They become more comfortable with me and we start talking about these things. Like I have a patient right now who we're talking about positions while she's having intercourse to improve her symptoms, you know? Like what physicians are talking about that?
Yeah, absolutely. You know? Yeah, I know. I'm not talking about that with my physician.
Right,
yeah,
exactly. So I'm giving practical tools that really dig deep and fix the practical problems, right?
In your personal and professional opinion, do you feel like it is something that should be built in to our healthcare system where it's like, okay, even before I decide to get pregnant, right, or have a child, maybe I should see a pelvic floor therapist? Do you think that's something that women should do or men should do? Or do you feel like you see your patients too late when they realize that they have a problem?
Yeah. So in a perfect world, everyone would be going to see a pelvic floor therapist before they decide to get pregnant. In a perfect world, a pelvic floor evaluation would be an annual visit, where it's like going to the dentist, you know, or going to your OBGYN, but it's specifically for the pelvic floor, right? Because the pelvic floor is a group of muscles, because we're talking about dynamic movements and mechanics, the right provider to assess that is a physical therapist, technically, right? Whereas physicians are trained on maybe bones, joints. They're trained on the organs and systems that can become have a dysfunction to them. They're not trained on movement and muscle mechanics, right? And so a lot of times I'm not just doing an assessment for the pelvic floor. I'm looking at the whole body, right? I'm looking at how they're moving, how they're squatting, you know, what position it is that's causing the discomfort. Do they spend a lot of time sitting for work? And in what position? What does that look like? You know, I look at, you know, their back and their hips. And I look at, you know, how they engage their core. You know, they say they're doing planks. Are they doing it correctly? Are they engaging correctly? Are they holding their breath? You know, how can I make that more efficient for them to be more successful?
Yeah. So what do you say to people who think that it's all mental? Because I feel like society does a really good job of saying, well, women just need to relax. Women need to be in positions where...
Or have a glass of wine.
Or have a glass of wine or not be stressed.
Yeah.
And you're saying, no, like there's a mechanical component attached to that. Like it's not just emotional.
Right. So it's not just emotional. Absolutely. And if a physician tells you to just have a glass of wine, that's a coping mechanism, right? That's not actually addressing the problem. So the pelvic floor is very tightly connected to your mental state. There's a biopsychosocial, you know, components that you have to look when you're working with someone with pelvic floor. Lots of trauma can be stored there. Yeah, trauma can occur directly to it, but a lot of people, when they get stressed out, what are they doing?
They clench up.
They can clench. Maybe they tend to clench more in the pelvic floor. Some people, it's more in the shoulders, and they're always having like neck and shoulder problems. So it's definitely bringing the full body approach, thinking mind body connection, not just body.
Okay. So as a mom, right? You're a mom to a 6-year-old daughter. Can you share about your own personal experience with pregnancy? I know earlier you mentioned something about birth trauma.
Yes.
People may not necessarily even attach trauma with birth, right? So can you share about your experience?
Absolutely. So I went in to deliver at 40 weeks because, you know, I thought that was what you did. I got induced at 40 weeks and 0 days. The birth was great. No issues really. It was like, I think I pushed like 3 or 4 times, right? When they were like, by the time they were like, okay, now you can push. I was like, okay, I'm doing this. I'm going to do it right now. And I did it. And I did it as quickly as I could because I was like, let's get this baby out. And I think because I did it so quickly in 3 to 4 pushes, that kind of, resulted in my tear. I had a perineal tear, a grade 2, which is not that bad, right? You can have anywhere from a 1 to a 4, but all that affects your ability to maintain your continence, right? to be able to pee when you want to or poop when you want to, right? And so I think that, you know, when we talk about birth trauma, even if you didn't have any injury, even if you had a vaginal and didn't have a C-section, that you still have the ability to have birth trauma. There's something that nobody shares with us is after birth, there's lots of swelling, you know, even if you didn't have an injury, there's lots of swelling down there. And there are things we need to do to try to control that for you, right? But the experience itself can be traumatic as well. There can be the physical and there can be the emotional tie to a birth trauma. And I think that oftentimes that can be stored in the pelvic floor, right? So birth trauma isn't just the physical trauma, it's also the emotional trauma that occurs with birth. And a lot of that can be stored in the pelvic region. Oftentimes women do tear. It can be a grade 1, which is the mildest of tears, to a grade 4, which is a significant tear that can affect, you know, your ability to hold in your bladder contents and your bowel contents, right? And if we're not addressing, you know, these issues, then oftentimes it can turn into some other issue down the line, right? And it can turn into pain with intercourse after delivery. It can turn into just constant tension and pain there. It can turn into like incontinence, you know, throughout the lifetime. And when you think back to our mothers, how many of them, you know, were having, you know, incontinence issues and just not sharing about it.
Yeah. Yeah, because I definitely know that my mother, she has the total of 4 of us, and she just never talked about it. And I think even when I'm now as a certified doula, I share some of the experience that I have with my clients, and she was saying, oh yeah, like that happened to me too. And I was like, Mom, like I never knew that. And I just think that that's just not common practice for people to just share with their friends or even their daughter, as you mentioned previously.
Right.
So do you feel like how did your experience as a mother influence your passion for educating others about pelvic health, particularly in the prenatal and postpartum phase?
Yeah. I think if I hadn't had my experience as a mom, as a pregnant person and as a mom, I don't think I would have been as interested in becoming a pelvic floor physical therapist. And I think that's a common thread for a lot of pelvic floor physical therapists, is that something happens to them and they're like, oh, this is a thing, this is a specialty, this is something that I can go into, and I'm more passionate about it because I've had my own experiences. So for some people, it's maybe they've had their own experience with vaginismus, which is pain with intercourse. Or maybe they've had their own hip issue that has resulted in pelvic floor dysfunction. Or maybe it's a man who's had, you know, discomfort with ejaculation. So it could be so many things, reasons as to why people decide to go into pelvic floor physical therapy. But I think that once you're in, you realize, once you take the courses and you realize how much of a need there is, you just become more and more passionate about it.
So are there any like lessons or tips that you tell your patients early on about how to deal with some of these issues? Like what would you say it's like your go-to?
There's so many. It depends on what's going on. I would say that my go-to with any person is to look at their breathing patterns, right? Because of the core canister technically involves the diaphragm. It involves the back and the abdominal muscles and then the pelvic floor, right? So if they're not breathing correctly, then that can mess up what's going on in the pelvic floor. So one of the first things I do is make sure their breathing's on point. And then the other thing I do is to make sure that they're pooping correctly, believe it or not, right?
Yeah.
Because that can cause some issues as well. And some people are like, oh, you know, I poop once every 3 days. Okay. And some people are like, oh yeah, I poop and it's always like pellets. Okay, we need to address that, maybe with changing some nutrition changes and making sure that they're completely emptying their bowels. Or some people say, yeah, I have to push a lot to poop. Okay, well that we need to address. Or they wipe a lot. They're wiping like 10 times. That is a significant sign of pelvic floor dysfunction.
Wow, I didn't even think about that. I didn't understand. I guess I didn't think that those two things were connected.
Absolutely.
Because my immediate thought would be like, oh, like I need to go see a gastrologist or someone to deal with that. But then you're saying that it could also be influenced by your pelvic floor.
Pelvic floor. And it's not to say that it's either or treatment, right? When it comes to certain symptoms, GI symptoms, there are some things that are like, yeah, you need to go make sure that gets cleared by a physician first. But there are a lot of things, especially GI-wise, people with IBS, people with constipation, you know, if all the things with the gastroenterologist is cleared, and you're still having some trouble, then you may need to see a nutritionist and a pelvic floor physical therapist.
Okay. Are there any so I would say, how do you tailor your treatment plans for your specific patients, right? Because it seems like there isn't a one size fits all.
You're correct. There is no one size fits all. I think there are lots of guidelines that are out there that try to help as many people as possible, but it's impossible for it to help everyone. And that's because everyone's so different. So when it comes to how I treat my pelvic floor patients, it all comes down to that assessment, that initial evaluation of me figuring out exactly what's going on, right? Is there a scar that's contributing to your pain? Okay, then we're going to mobilize that scar, and I'm going to teach you how to mobilize that scar, right? Is there weakness? Where is the weakness? And what is going to be the thing? What are the 2 or 3 things that's going to give you the biggest bang for your time buck? That's what I talk to a lot of my patients about, is that there's so many things you could do, but let's focus it on what's going to give you the best result. And when I give recommendations for my patients, it's not like a 20-minute thing that they have to do at home. Most people don't have time for that. Definitely not parents, right? And so my goal is to give them, things that they can fit here and there throughout the day. So if they're sitting at a desk, okay, you're gonna at your lunchtime, you're gonna get out of your desk, and you're gonna do these 2 exercises that take 2 minutes, and then you're gonna move on with your day. And that way we're inserting it into their day so it becomes more routine and less of a burden.
Okay. So you had mentioned that that you were really passionate about pelvic floor therapy after your experience.
Mm-hmm.
So what would you say is the most rewarding part about being a pelvic floor therapist?
I love when my patients, especially my prenatal patients who come to me for birth prep, like push prep, I love when it finally clicks, the movement that they need to do down there, and they've timed it with their breathing, and they're like, oh my gosh, yes, I feel it. I know exactly what I need to do. That's the best feeling.
So if there are a few things, right? Because I love how you brought some of your props. So if there are a few things that women could do to start taking care of themselves, right? To make sure that their pelvic health is, I guess, optimal early on, what would you say what are some of the tips that you would suggest?
Making sure you drink enough water is one of the biggest things, because some people may have urinary frequency or urgency. So frequency is when you go more than once every 2 hours. And then urgency is when you get a sudden onset of the feeling that you have to pee, and sometimes make it and sometimes don't make it, right? In time without having an accident. And so for a lot of people, the reason why they get this is actually because their urine is too concentrated. And then it irritates the bladder. The inside of the bladder has a bunch of nerve receptors. And if those get fired, then it's like, oh, it's time to pee, even though it may not be full. They're like, oh, it's time to pee. And what does the bladder do? It contracts and tries to push the contents out. And so that's what can contribute to frequency. And so a lot of times people have this, and it could be simple things like they're drinking too much coffee, or they're drinking coffee right before bedtime, and that's causing them to wake up too often to go pee. Or they have lots of sparkling water or things with lots of carbonation. Caffeination can also irritate the bladder. Spicy foods, chocolate is another one, right?
And you're saying all the things that I love right now.
That's not to say, but if you don't have any symptoms, then you don't change anything, right? Now, if someone were to have symptoms, I'd say, look at what you're doing and choose one that you can live without and see if that changes things. And you do the small steps, right? So I would say make sure that you're drinking enough water, and enough means when you look at your pee, it's like a very light lemonade, right? It should not look like iced tea.
Okay.
It should not look like iced tea. Okay. The other thing is to make sure that you're having enough fiber in your diet, because if you're not pooping regularly and you're having to push and strain a lot, that's not good for your pelvic floor either.
Okay. So if you don't mind sharing, so you had mentioned that you pushed, right? So you had a vaginal delivery?
I had a vaginal delivery.
Yeah. So what do you tailor your treatments for patients who had C-sections, right? Because technically they didn't birth through their pelvic floor. What approach would you do for those specific patients?
So they would still be assessed internally if they're having symptoms that warrant the internal assessment. But a lot of people who've had C-sections still can have pelvic floor issues, right? Because they carried the baby for 40 weeks, right? And sometimes it's not just the actual delivery that causes pelvic floor dysfunction. It's the length of time that they've had to carry this child internally in their uterus. And so for C-section moms, a lot of people don't think about what it's like to have a C-section. A C-section is by no means the easy way out of delivery at all, right? When you see a C-section, what we see outside is just the incision outside here, but they've gone through so many layers of tissues, right? They go through the skin, they go through the fat layer, they go through the fascia, which is what covers the muscle. Then they split the muscle down the middle, so they don't cut through the muscle, they just split it down the middle. Then they go through the peritoneum, which is a thin layer of fascia. And then they go through your uterus, right? And then from the uterus, they go to the amniotic sac. And then finally, they get the baby.
So that's like 7 or 8 layers, right?
It is. And so what happens a lot of times, I don't have it depicted here, but you have nerves, small peripheral nerves that pass through here too, and they can get injured too. So a lot of pregnant moms, postpartum moms, will have numbness around the area, right?
Wow.
Or they'll have pain around the area. Or because it's 7 layers deep, they'll have puckering of the tissue, right? Because the tissues don't only scar down this way, they can scar down deep one to the other. And in order for things to move freely, they need to be able to kind of run over each other seamlessly. And when you have scar tissue between the layers, that can limit how you move, how you contract your core, and how you recover from something like an abdominal surgery. Essentially, a C-section is an abdominal surgery.
Yeah, that's something that people don't mention, that C-sections are like major surgeries.
Major abdominal surgery.
And I think, do you feel like because of the fact that they're so common, they're kind of diminished in how invasive they are?
Absolutely. The C-section rates in Miami, I think, are 30 something percent?
Yeah, like they're really high, yeah.
They're way higher than they need to be. And when you think about all these other abdominal surgeries that are had, they get physical therapists in the hospital.
Yes, afterwards, yeah, or even in some like gallbladder surgeries, or even just some appendectomies?
They
Yeah.
will get a physical therapist acutely in the hospital to help them with getting out of bed, starting to walk.
But no one does that for the moms.
Very few hospitals in the U.S. are doing that for post C-section moms. But they're being told, don't carry anything larger than your baby.
Yep.
And they're being given minimal to no instruction on how to take care of the wound. And they're not being monitored. Their vitals aren't being monitored as they start to increase activity in the hospital.
Yeah.
Because they're just saying, oh, it's time to walk, go, or go ahead, take yourself to the bathroom, you need the walk. But no one's monitoring how they're responding to physical activity.
Yeah. So because of the fact that they went through all the layers, would you say that the exercises for them are also different, right? Because I can't imagine that, let's say, for example, doctors mentioned 6 weeks postpartum, you can start exercising. However, with the C-section, I'm sure it's different. So how does a mom who recently had a C-section, how does her exercise routine or how does her postpartum health look like?
I think everyone's postpartum recovery is going to depend on what they looked like before pregnancy and what their activity was like before delivery, right? That's going to affect how quickly they can return to physical activity. In addition to, the birth, the way they birthed will affect how quickly they can get into physical activity, right? So someone who had a vaginal birth and was very physically active during pregnancy maybe they can start running at 12 weeks, right? Definitely not 6 weeks.
Yeah.
But maybe they can start running at 12 weeks, or maybe they can start, strengthening enough to return to running at 12 weeks. Maybe they start the strengthening at 6 weeks, right? To return to running at 12 weeks. Someone who's had a C-section, that's going to be longer because the core is significantly, has to be active during running, right? And when that doesn't occur, when someone's not ready to return to physical activity, and they do, what can usually happen is that then they'll have symptoms. Maybe they'll have pain at the abdomen of the C-section scar, or maybe they'll feel pressure or pain down there. They don't know what's going on, but they're just like, oh, it's pressure and it's pain. I don't know what's going on. But they've been told at 6 weeks, go ahead and return to activity.
Yeah, to like normal life. It's like 6 weeks seems like to be like that metric, but you're saying for others, it's much longer.
No, for the most part, it's going to take most people at least 4 to 6 months to really feel comfortable in exercise, and to feel like their body is back to normal, like 18 months.
Wow.
after pregnancy and delivery.
So you feel like because of the fact that there's this, I'm sure you've heard of it, right? The snapback culture. I feel like that puts so much pressure on women to go back to their original state, to go back to their original bodies. But then it's like, no, your body is different. You just had a baby. So you're going to look like someone who just had a baby.
Right. So the body is going to be different, whether we like it or not.
Yeah.
The body is going to be different. And the body's going to respond differently to things you used to do.
Yeah.
Right. That's not to say that you can't get back to it, but we have to really give ourselves grace. A lot of people like to use that term.
Yeah.
We have to give ourselves grace.
Mm-hmm.
We have to give ourselves the time to truly recover. And if we skip some steps, we may not be able to get back to where we want to be. Right.
Okay. Yeah, absolutely. Yeah. So can you tell me a little bit about your business and the types of clients that you service? I'm really excited to hear about some of the work that you're doing.
So my business is called Jae Physical Therapy. It's Jae is Jae. It's after my daughter's middle name.
Oh, that's really sweet.
And I'm located in Davie, Florida. And I treat men and women, but who I really want to target is and work with is prenatal moms in order to prepare them and make them feel good in pregnancy, prepare them for labor and delivery, and to help them have the best possible postpartum recovery and outcome.
Okay, awesome, awesome. So what can listeners find more information about your business, about where can they find you on your socials?
Sure.
Can they get more information?
Sure. So my website is www.jaept.com. I'm on Instagram as the Pelvic Trainer.
Okay.
I have some, I'm going to start to be putting some more things on YouTube to educate.
I've seen some of your YouTube videos.
Yes.
They're really good.
Thank you. And really what my next goal is to continue to work more in speaking, to educate doulas and midwives, so that we can really get this maternal mortality rate down as much as possible.
Yeah.
I think that if we educate women on the right ways to use their pelvic floors during delivery, I think we can limit how quickly sometimes people recommend C-sections, because really C-sections are where the biggest risk lies. Right?
Yeah.
There's a bigger risk of hemorrhaging, which is the number one cause of deaths, right? So if we can really limit and decrease C-sections, I think we could really address the maternal mortality rate.
Yeah, absolutely. And in honor of Black Maternal Health Week, I think these conversations are super important to have with our audience. So I just want to say thank you again for joining us. This was a great conversation. It was very informative. And hopefully it was able to help you or someone you know, or even someone you support who may not necessarily have the confidence or may not even know that they have access to some of these resources. You can also check out Dr. Rodriguez at her site. I'll put all the details in the show notes. And again, thank you again for coming.
Thank you so much for having me.